good afternoon to all present. I, Dr. Richa Gupta, working as a coordinator of the project in Department of Telemedicine, PGIMER. Welcome you all in this webinar organized by TSI Chandigarh chapter in collaboration with Department of Telemedicine, PGIMER Chandigarh. The webinar is on diagnosis, prevention and management of tuberculosis, and we have the resource person, Dr. Nabaneeta Dash, who is consultant pediatrics and working in the Department of Telemedicine at PGIMER Chandigarh. So I offer my great welcome to all of you and to Dr. Nabaneeta. Welcome, ma'am, and over to you. Thank you.
Thank you, Dr. Richa. Good afternoon, all. For those of you who know me, do not know me, I'm Dr. Nabaneeta. I am a pediatrician who has pediatrician and a qualified pediatric infectious disease specialist. Currently, I'm working in as a consultant in pediatrics in the Department of Telemedicine, PGIMER Chandigarh. So I'll be speaking about tuberculosis. It's many of you know what is tuberculosis. There is a lot of guideline. All of us know that TB is one of the endpoints that we want to achieve. But many of us manage TB, but many may not be clear how to manage TB, and when we are faced with complications, there may be certain doubts. So first we'll present, and if any questions, you can ask either in between or at the end of the presentation. Welcome all. So TB has got many names. It's one of the oldest known infectious diseases. It's known as white plague. Also, it was known as white plague because of the paleness of the patient who got infected with TB. So evidence of osteoarticular TB can be found even in Egyptian mummies. And in Indian and Chinese literature dated back to 3000 and 2300 years have also described TB disease. But we came to know about the disease, or that MTB, Mycobacterium tuberculosis, causes the TB disease when the MTB bacteria was discovered by Dr. Robert Koch in March 24, 1882. That's the day when we celebrate the World TB Day. So it was the most important step towards the control and elimination of this deadly disease. At this time, this is Dr. Robert Koch. At that time, TB was quite rampant in Western world or all over the world. It killed almost 1 in 7 persons. So you can imagine how deadly this disease was. So this is the current epidemiology. This is from WHO. So in 2022, this was the incidence of TB in the country, in the countries. This has been marked. TB is present everywhere, but more than 1 lakh incidents, this has been marked. So you can see India has one of the quite big bubble. So more than 2 lakh is the incidence of the country. So India is one of the topmost in the 8 highest incident countries. So, so not all is bleak. We have reduced TB deaths. So after the start of the TB drugs, and we have several programs, the National Tuberculosis Elimination Program, and all the money and the efforts that is going towards TB control. So we have seen a steady fall in the number of TB deaths, both in people living with HIV and in HIV negative people. So that's a very good thing that we have seen. Although there were some blips due to the COVID-19 pandemic, but still it is less than what was there before, 10 years before. So some myths and facts. TB is caused by Mycobacterium TB. It's an airborne infection. So TB is spread from one person to another through air. And so when a person coughs, sneezes, sneezes, talks, the droplets containing the bacteria are released into the air, and it remains suspended in the air and can affect the other person. So many a times we see, especially for children, when children are not allowed, you cannot eat food or certain things. So TB does not get spread by food, water, by shaking hands, or from toothbrush, clothing, or by hugging or kissing. So when to suspect TB? So there can be, these are some of the symptoms, but there can be many other symptoms depending on which system it is affecting. So it is usually TB should be clinically suspected based on the following symptoms. Usually they present with fever for more than 2 weeks, cough for more than 2 weeks. There is a significant weight loss, that is more than 5% of body weight loss over the last 3 months, or unintentional perceptible weight loss. Like people may not have measured, but they will be telling that our clothes are quite loose. Then if there is hemoptysis or night sweats, these are typical, but there can be other symptoms depending on the organ involved. So in pediatrics, which is one of the areas where it is difficult to suspect, and when children come with us, they usually have much disseminated disease. So children many a times present with persistent fever for more than 2 weeks without any known cause. There may be presence of unremitting cough for more than 2 weeks, weight loss more than 5% or no gain in weight for the past 3 months despite adequate nutrition, or failure of nutritional rehabilitation in children who have presented with severe acute malnutrition. So they may present, there may be a history of contact with pulmonary TB in past 2 years, or there may not be any history of contact. So these are the typical signs and symptoms of TB in adults as well as children, and this pertains to pulmonary TB. Now, TB not only affects the lungs, but also affects other organ systems in the body. When it affects the systems other than the lungs, it is known as extrapulmonary TB. So extrapulmonary TB symptoms will be based upon which organ it has affected. So lymph node is one of the common extrapulmonary TB. So it can cause lymph node enlargement. There can be abscesses. There can be chronic draining sinuses at the lymph node sites, and the lymph nodes can be anywhere, right from the cervical to axillary to inguinal, or even intra-abdominal or mediastinal lymph nodes. So any of the lymph nodes can be affected. Musculoskeletal system can be affected, in which case there may be gibbous, back pain, arthritis, to name a few. Usually presents as monoarthritis of large joint. When the GI system is affected, it can present with abdominal pain, vomiting, change in stool pattern. On examination, there may be hepatosplenomegaly. It can even present with symptoms of subacute intestinal obstruction like vomiting, constipation, abdominal distension. It can present with ascites also. CNS TB, that is one of the dreaded forms of TB because of the poor outcomes that we have. It can present with features suggestive of meningitis, that is fever, headache, neck rigidity, all the meningeal signs being positive, or it can present with focal deficits, focal localizing signs like seizures, altered sensorium, can present as encephalopathy, or present with cranial nerve palsy. And in children, it can present with increasing head size. When the parents say the head size is increasing, child is irritable, there is loss of developmental milestone, and there is a history of TB contact, child is not gaining weight. There could be other causes of meningitis, but TB is one of the important causes of chronic meningitis. It can affect eye, so optic TB, which can present with blurred vision, photophobia, floaters, because it usually causes uveitis. So cutaneous TB also can be there, which can present as persistent warts, varicose lesions, or discharging sinus. So the persistent warts or these discharging sinus, the underlying lymph nodes may be enlarged, and which has broken up to form as discharging sinus with non-healing ulcers. There may be scrophulodderma, which is the lymph node TB. Along with that, the upper skin above it is involved. Varicose TB also can be presented. Then there can be genitourinary system also can be involved, in which patients can present with urinary symptoms like increased frequency of urination, but the lower urinary tract symptoms, increased frequency, or there may be pain during urination. Males can present with scrotal pain or scrotal swelling. Females, one of the important cause of primary infertility in female is TB, TB of the tubes. So whenever a female is presenting with primary infertility, we must rule out TB, especially in a country like us. And they can present with menstrual disorder, both hypomenorrhea or menorrhagia. So, or pain during menstruation. So all these could be the complaints. Now these are the local, this depends upon the system involved, and along with this there may or may not be presence of systemic symptoms, but usually there are systemic symptoms in form of weight loss, fever, loss of appetite, loss of energy. So these systemic symptoms might be present. So when all this constellation is present, then we can suspect TB in them. So this plus if there are certain risk factors, like if they are patient living with HIV, if he or she is a smoker, alcoholic, diabetes, at both the ends of age, like children or elderly. So these makes them very much susceptible to TB. As we all know that TB bacteria, once it can infect us, but immediately after infection, it may not cause disease. It may lie latent. Only if our immune system is not able to handle the TB bacteria, then only we have disease. So the TB may remain latent with us for several years, or maybe we can get TB immediately after contact. But if presence of these risk factors will make the TB bacteria become active. So coming to diagnosis, so in a person you have suspected TB, now how will you diagnose TB? So there are one is clinical symptoms, then there will be imaging, and then there will be lab diagnosis. So microbiological diagnosis of TB is very, very important, because without microbiological diagnosis, treating TB empirically is currently not recommended, as we have much sensitive test which was not there maybe 15-20 years before, but current tests are quite sensitive. So one of the earliest tests, that is so we have direct detection of the MTB, indirect detection, and nowadays the molecular or the genetic diagnosis. So the one of the earliest tests is the AFB smear or the Zeal-Nielsen staining, where we can see this acid-fast bacilli in the sample. So when this acid-fast bacilli is seen, we say that it gives us a presumptive diagnosis of TB, though there can be other acid-fast bacilli, but MTB is the most common acid-fast bacilli that we see in a patient suspected with TB. So microscopy is one. There are other forms of microscopy like fluorescent microscopy, etc., but I'll not go into that. But this is microscopy. But we can see microscopically only when the TB bacteria load is high in the particular sample that we have taken, whether it is sputum, whether it is lymph node, whether it is biopsy. If the load is high, then we see. Problem happens when we have paucibacillary disease, which is seen in children, seen in HIV positive, seen in elderly. That's when the bacterial load is less. So our AFB smear will come negative. So what to do then? So that's why current recommendation is to do TB DNA detection. There are many tests available, that is basically by PCR. So current standard of care is the first test that we now recommend is CBNAT, or cartridge-based nucleic acid amplification test. So that is Gene Expert or Mobilio Labs TrueNAT test. So I'll come to that. So this is the PCR-based test. This is the current recommended test. First line test is this, not microscopy. Then indirect detection is by culture, liquid media and solid media culture. And then there is resistant detection is there by genotypic and phenotypic method. And then strain typing is also there. Now that is like for research purposes generally. Usually while treating a case, we don't need this. So just an overview. So this is from our PMDT India, Programmatic Management of Drug-Resistant TB. So all TB patients, whether we are suspecting TB or whatever TB, so the first test that is recommended is NAT. That's what is recommended, because NAT will detect whether there is TB bacilli present or not, and if it is present, whether rifampicin resistance is present or not. We'll come to this slide again. So moving ahead. So what is NAT? NAT is nucleic acid amplification test. So basically it's a real-time PCR based amplification of a particular target region of the MTB complex. Now, why I'm saying MTB complex? Because MTB complex consists of MTB bacteria as well as 2-3 other bacteria. But main important is MTB bacteria. So it detects this gene, the RPOB gene. This is the target which is detected by this PCR. So once you detect the RPOB gene, you identify there is MTB. Now, if a mutation is detected in this gene, then it means rifampicin is resistant. And 90% of time, if rifampicin resistance exists, there is coexistent isoniazide resistance. So we can classify them as MDR or multi-drug resistant TB. So for TB diagnosis. So therefore, NAT is very, very important because it not only helps us in diagnosing the TB, it can detect in possibacillary sample, as well as at the same time, it gives us whether it is a drug sensitive TB or drug resistant TB. So wherever available, this should be the first test that should be done and not microscopy. So two commercially available things are available: Cepheid Diagnostics Gene Expert and the Indian test, that is TrueNAT. So both WHO has said both are equally sensitive, both are equally specific. This is a costlier test, requires electricity supply. Always there should be electricity supply and a particular ambient temperature, whereas this one is battery operated, so can be done easily in the peripheral centers. So besides NAT test, so other NAT tests which have come into foray are the more sensitive test, that is Expert Ultra. So Expert Ultra, what improvement is there? Here the limit of detection is only 16 colony forming units, whereas in the normal Expert is 113, whereas even if 16 bacteria are present, MTB complex, it will detect because it has newer targets. Besides RPOB, it has these two newer targets. So sensitivity is much high, but because of higher sensitivity, the specificity gets slightly lowered. But if we are sending sample in persons whom we are suspecting TB, that is our pre-test probability is high, it's a very good sensitive as well as specific test, and the turnaround time is similar, just 1 hour. 1 hour from after the sample has been processed. Now this is another test which is in foray, maybe available in the private sector also. So MTB XDR. So this is done as a reflex test. Once your MTB is positive via ultra or by normal expert, you do and there is rifampicin resistance is detected, you do this test to detect resistance to other drugs like isoniazid, fluoroquinolone, injectables, and ethionamide. Here also specificity is high, but the limit of detection is like that of normal ultra, that is the normal expert, that is 113. So these are newer tests. Just know that these tests are available. Ultra might be available in certain centers. So how to interpret? Now you have done the test. Now how to interpret the NAT report? The NAT report will come to you as whether MTB is detected or not. And there will be a semi-quantitative determination of bacillary load. Results will be reported as MTB detected, high, medium, low, very low, or trace. Trace is reported with Expert Ultra and with the TrueNAT. So once it is reported as trace, MTB detected trace, the rifampicin resistance is written as indeterminate. Now what do you mean? We'll come to that. So when you get a NAT report, MTB detected, semi-quantitatively how much of MTB is detected and rifampicin resistance is detected or not comes to you. So you can do this, you can know these three things with the help of NAT report. Now what do you do with trace and indeterminate? So this is seen with Expert Ultra because the limit, as I said, the limit has been much lower to only 16 colony forming units. So in possibacillary sample, because the limit of detection is so low, we can detect even trace amounts of MTB bacteria. But the genetic amount or the genetic load is so less that rifampicin resistance could not be determined. So that's why rifampicin resistance is written as indeterminate. So what do we do? WHO says that in HIV positive people, in children, and those with extrapulmonary TB, where we are suspecting extrapulmonary TB and the sample is from that extrapulmonary TB site, the trace calls are to be considered positive and should be started on drug sensitive TB treatment and not drug resistance. For all others, we have to repeat the test on fresh sample and the result of second sample has to determine our action. If both the samples are trace positive, then to consider as TB and treat as drug sensitive TB. But the background should be high pretest probability of TB disease. Now, if you say rifampicin resistance is not detected, then DST should be performed to determine rifampicin resistance. Okay. If you have any questions, you can ask in between if you have. Now for the thing, this is like what sample should we take? Not all TB sputum sample is appropriate, because if it is extrapulmonary disease, if we take pulmonary samples, then it might not be appropriate. So we have to take sample from the site where infection is present. So when we are suspecting osteoarticular or musculoskeletal TB, we should take biopsies from the joint. Similarly, when we are suspecting pleural, besides the sputum sample, we should take pleural fluid. For meningitis, CSF. For lymph node TB, it should be from the biopsy sample. For urogenital, urine should be taken, early morning urine sample. And for female genital tract TB, many a times it so happens that females have been, because I see pediatric, we see congenital TB and mother has no TB. How was TB investigated? Just an X-ray and sputum was done, which was negative. But actually we should do this endometrial biopsy or curettage, that because the TB lies there. So if you take sputum, it will become negative unless she has disseminated disease. Then gastrointestinal, similarly tissue, pus, peritoneal fluid, and if there is any lymph node biopsy, or if there is a necrotic intestine which we are taking it out, then that biopsy sample should be sent for TB test. And what should we send? We should send nucleic acid amplification test for culture as well as for histopathology. We should not send only for histopathology and sit. So we should send microbiological test also. That's very, very important. So FB smear, NAT, culture, and histopathology. That's what should be done. And if culture is positive, we should ask for drug susceptibility testing. And in pulmonary TB, as we know, adult sputum sample, induced sputum or bronchoalveolar lavage. In pediatric, so the problem with pediatric is the children swallow sputum. So if your sputum samples are being sent, it will turn out to be negative. So in children, usually what we do here is induced sputum or gastric lavage or aspirate. And where we are still suspecting we are not getting anything, then bronchoalveolar lavage. But all these are done in tertiary centers. But pediatrics, so therefore we should remember what should be done. So other supportive investigation, so we can do imaging, X-ray, USG, CT, MRI. So all these are supportive. There are certain features which will tell us, okay, this is probably TB, but it will not tell that it is not confirmatory and there will be no microbiological diagnosis. So therefore, always don't base your diagnosis only on imaging. But many a times we are pushed to, but always try and find out microbiology. Other things like ADA, especially in adult, it is important. In children, not much role has been there. More than 40 international unit per liter has been taken to be important. But in children, there is always a controversy. So we mostly do not rely on ADA. Then histopathology of the biopsy or FNSC sample, we can see caseating or necrotic granulomas. Although these are specific for, these are indicate TB, but this is not 100% specific or 100% sensitive. So there may be granulomas with other diseases like histoplasmosis or in even other autoimmune diseases like sarcoidosis. So we should be careful when we are seeing granuloma, whether it could be other diagnosis could be present. Cytology will, so if we are taking a fluid like ascitic fluid, pleural fluid, CSF, it should be sent for cytology and biochemistry. In TB, usually a lymphocytic predominance is there, but saying that we can, early disease, there can be even neutrophilic predominance. Low glucose and high protein usually characterizes TB fluid, but there can be exceptions. So these are few imagings which are, it's not like representative, only this is seen, but these are few imagings. Like this was a CT scan which was done in a girl. So typical tree in bud appearance is seen. But it's not that. Hello? Does anyone wants to ask? So it's not that tree in bud is seen only in TB and nothing else. But if you're seeing tree in bud, you have a corroborative history, you suspect TB. So this is the musculoskeletal. We see that wedge compression and there is a prevertebral collection also is seen. And TB meningitis, like we see meningeal enhancement, basal exudates, and then there is hydrocephalus also, basal exudates with hydrocephalus. Then there is tuberculomas, and there can be infarct. So all these are supportive in TB diagnosis. So what I wish to say is you should take not one test for diagnosis. You should take every test together and make a diagnosis. So as I explained, so NAT is what is recommended as the first test, and then after rifampicin resistance, so we are not going to discuss this today, maybe another class. So if rifampicin resistance is not detected, what we do is we send the sample for first line LPA and drug susceptibility testing. Now what is LPA? LPA is another genotypic test, another PCR. Just remember, it's another type of PCR. These are the LPA sheets. And it detects, first line LPA detects resistance to INH, rifampicin and ethionamide. And then there is something called second line LPA, which we do if rifampicin resistance is detected. This is to detect resistance to second line drugs, which are fluoroquinolones and injectables. But the problem with LPA is it can be done only on 1+ positive AFB smear positive sample. So either from sample itself or from positive culture. So because especially in children, this smear positivity is very rare. So that's why we do LPA only on culture positives. So turnaround time is 1 to 3 days. So culture. So culture is usually done to characterize, then for drug susceptibility testing. So therefore culture is done. So culture, currently solid media culture is not recommended. But if we do not have liquid culture, we can do solid media culture. LJ culture is, media is mostly done, but there are other culture media is also present. But NTP, our National Tuberculosis Elimination Program, does not recommend solid media culture. So liquid media culture is Bactec midget 960. So basically these are the midget tubes. They have a fluorescent dye at the base. What happens is when oxygen gets consumed by the growth of any bacilli inside the tube, it results in fluorescence. And this fluorescence is detected by this machine. That's how we know that there is a growth in the tube. Once there is a growth, fluorescence occurs, we take out the tube. That growth is tested for by ZN stain and other phenotypic and biochemical properties and even genotypic tests are done to identify the TB bacilli, because sometimes non-TB bacteria will also grow. So therefore we have to identify what growth has occurred. So this is the average time of detection. So smear positive cases, the liquid media culture, within 8 days we get a culture report, positive or negative, whereas solid media it is 16 days. So we're losing 1 week. In smear negative, the liquid culture usually within first 2 weeks, culture flat. If it has to become positive, within 16 days. And solid culture, it takes around 4 weeks. But lab does not release negative reports till they have incubated the midget tubes for 6 weeks or 42 days. So if it has to grow, it will grow within the first 2 weeks. If it does not grow, you will get the negative report only at the end of 42 days. So I'll tell you why culture is negative or why NAT is negative with the help of a case. This is a case we saw recently in August. So he came from Saharanpur in Uttar Pradesh. He was an 11-year-old boy who came with history of intermittent fever, swelling of left elbow for 5 months, non-healing ulcer over the left elbow and over this index finger, and there was a pus which was discharging sinus, which was discharging pus. X-rays, there was this osteomyelitis. Here also osteomyelitis was present. So anybody would suspect TB. So he was suspected as TB, as a probable osteomyelitis of ankle joint, and he was started on ATT under NTP in Uttar Pradesh. But it was probable. No microbiological test was done. So what happened? On ATT, the ankle joint healed, but the elbow joint got swollen and the swelling got worse. There was chronic discharging sinus. So what was done? The ATT was extended to 1 year period, but still there was no response. Hence he came here to PJ. So what we did here, we wanted to investigate further. We got him admitted that whether it is actually TB or not, because we had other differentials in mind also. And if it is TB, whether there is drug resistance. So we did a synovial biopsy. And the synovial biopsy histopathology did show necrotizing granuloma, but the CBNAT showed rifampicin resistant. The AFP smear was negative, midget had no growth, so he was classified as drug resistant TB and started on drug resistant TB treatment, and he responded well. So there lies the importance of microbiological. We all know from the clinical presentation that he is TB, but whether he is drug resistant, drug sensitive, only microbiological test will tell us. because currently government does not recommend empiric start of previously there was category 1, category 2. Now there is only one category. If you are suspecting drug resistance, if there is any in any previously treated cases, whether it is recurrent, treatment after loss to follow-up, treatment after failure, you have to rule out drug resistance. And then if you have ruled out drug resistance, you have to give the same regimen, 2 HRZD plus 4 HR, isoniazid, rifampicin, pyrazinamide, ethambutol, and 4 HRE. This is for all. What is the special situations are? In CNS TB, the treatment duration is 12. 2 months of intensification phase, 10 months of continuation phase. Ocular TB, it is 2 months of HRZD followed by 7 months of HR. Why 7 months and why HR? Ethambutol, it can cause optic neuritis. Therefore, E is removed. Prolonged E is not given. And since E is removed, we are extending the continuation phase by 1 month. Only for pediatric osteoarticular TB, the treatment duration is 12 months. But for adult, it is same 6 months. Now, at the end of intensification phase, if it is a pulmonary TB, we do again sputum AFB smear and culture. If it is positive, AFB smear or culture is positive, then intensification phase can be extended by more than 1 month. Otherwise, usually we do not extend. If you are going to extend, please consult an expert and then extend. So, the problem that we face quite commonly is ATT-induced hepatitis. So these are the people who are at risk, those with underlying liver disease, alcoholics, drug abuser, people living with HIV, and elderly. So when do we say? When there are symptoms like pain, vomiting, icterus, yellow urine, and liver enzymes are more than 3 times the upper limit of normal, along with bilirubin is also raised. But if only liver enzymes are more than 5 times the upper limit of normal, bilirubin may be normal or raised, we classify it as hepatitis. And if the symptoms are otherwise suggestive, then we should rule out other causes of hepatitis, like infective hepatitis, alcoholic, but that's depending patient to patient basis. So now if there is ATT-induced hepatitis, we stop ATT for a week and repeat LFT. If the disease is severe and you even for 1 week you cannot stop ATT, then you give other hepatosafe drugs like ethambutol, levoflox, amikacin, ethanamide, or cycloserine. Choose one of them. 3 drugs you give, and then repeat the LFT after 1 week. We start ATT only if both the liver enzymes have fallen less than 2 times the upper limit of normal and bilirubin has become normal. Then only we restart ATT. So we can restart ATT by 2 ways: sequential or incremental. This is usually preferred because of the easier way in which can be given. Sequential, we give 1 drug, that is rifampicin, then repeat the LFT after 1 week, then we give isoniazid, then repeat the LFT, and then we reintroduce pyrazinamide. And while we are reintroducing drugs, if he is on hepatosafe drugs, we stop one drug, one after another. So this is what we usually follow. If in doubt, please consult seniors, please consult experts. Then role of steroids. So proven role in TB meningitis. 4 weeks of full dose steroids. In adults, it is 0.4 mg per kg per day. In pediatrics, it is 0.6. This is dexamethasone, 0.6 mg per kg per day. Prednisolone is same, 1 to 2 mg per kg per day. In TB meningitis, it is 2 mg per kg per day. Full dose for 4 weeks and then taper over 4 to 6 weeks. TB uveitis, usually if severe inflammation is present, especially in the anterior chamber, we give local, that is steroid drops. Systemic, if you want to give in TB uveitis, please do it in consultation with uveitis experts. In other forms of these forms of TB, depending on patient to patient basis, steroids may be considered, especially those with large pericardial effusion or early pericarditis, miliary TB presenting with alveolo-capillary block, that is with hypoxia, not improving on oxygen therapy, or those with endobronchial TB. In rest of the TBs, usually steroids are not indicated, and there have been current recent evidence that that steroids might be harmful when started in miliary TB. So this is always plus minus, but these are the two. This is the only indication till now. So coming to other tests which we think will help in diagnosis of TB. So few slides on that. So MAN2 is a common test, as we know. So basically, what does MAN2? This is how MAN2 is done. we take the tuberculin syringe, give an intradermal injection, and then read it horizontally, never vertically. It's horizontal. So what does it prove? Basically, it shows that a person immunity is reactive to tubercle bacilli. It may be MTB, it may be bovis, it may be NTM, but it cannot differentiate between active or latent infection. And there is always cross-reactivity present. So if MAN2 is positive, does not mean that he has TB disease. It just means that he has been exposed to tubercle bacilli and his immune system is reacting to the tubercle bacilli. So positivity, the cutoff varies. For us, it is more than 10 millimeter is positive, but for HIV, it is 5 millimeter is taken as positive because their immune systems are not acting good. So even 5 millimeter is taken as positive. So it is not required for diagnosis. Currently, NTP does not recommend MAN2 for diagnosis, especially for pediatric TB, it is not recommended for diagnosis of disease, but it can be used for diagnosis of exposure. So many of us have an idea. So you see quantiferon TB gold, that this is the test for TB. Many will come with reports that TB gold has been done, it is positive, so this is TB. So these tests are costly, can range from 3,000 to 4,000 rupees. But again, it does not detect TB disease. It detects person's immune reactivity to MTB. And but the thing is, it has more MTB specific antigen. So there is no cross reactivity with BCG or non-tubercular mycobacteria. But it does not detect active disease or latent infection. So hence does not diagnose active TB. The disadvantages being it's an expensive test. Doing the test requires lab facility, and interpreting the results can be difficult in case of non-trained people, and there is limited data on use in less than 5 years, immunosuppressed patients, serial testing. Many will come with the report that I did this test 2 days back, it was positive, now it is negative, now what shall I do? So serial testing can give weird reports and recent exposures. So within that's true with other TB tests also. So only after 3 weeks the immune system starts reacting, 3 to 6 weeks. So if exposure occurred within a week you are testing, the test may be negative. So this is another test, which is the new test. Different manufacturers have this test, but Serum Institute of India is taking out this test, CTB test. It's like skin test, MAN2 test, but the antigen, instead of the MAN2 antigen, it is the MTB specific antigen, which has ESAT6 and CFP10, which is again, it's a TB specific antigen. There is no cross reactivity with NTM and BCG exposure. But again, it cannot differentiate between active disease and latent infection. So that's what was TB. Now, sometimes we have this complication. Sometimes many of you would have heard paradoxical reaction. You have started ATT, the patient responded, and again there was deterioration. So the clinical and or radiological deterioration that occurs after initial improvement after the start of appropriate ATT. But we have to rule out there is no drug resistance, there is no non-compliance, it's not adverse drug reaction. This is the photo of a lady who had been started on ATT with lymph node TB, and 2 months into her therapy, she developed another swelling, and there was this sinus, discharging sinus. Now, the problem was when she was diagnosed, it was again empiric diagnosis, there was no microbiology present. Now, how do we know that this is not drug resistance and this is paradoxical? So that's why microbiology is important. So common in CNS and lymph node TB. So when you are diagnosing paradoxical reaction, it's a diagnosis of exclusion. If there is paradoxical reaction, the treatment is nothing new. You have to just continue ATT. But in few cases, only in consultation with experts, it requires immunosuppression, from steroids to other immunosuppression. Because paradoxical reaction occurs when the immune activity recovers and there is immune activity becomes high, causing all these things. So once you have diagnosed, you have to follow up with whether there is clinical improvement or not. You have to started the treatment. If there is any side effects of medicine, adherence to therapy, always look at the drugs the patient is taking, because you might have prescribed something, they must be taking something. They must not be, instead of 2 medicines, they must be taking 1. Instead of 3, they must be taking 4. So please always see and always advise the patients to bring their medicines and show it to you. So usually if it's a sputum positive, usually at the end of intensification phase, we say to repeat the midget and FB smear. When they come in follow-up, you can see their LP and midget results which would have come. LFT is usually not routinely required unless symptomatic. Usually baseline LFT is only required, and imaging may be repeated at the end of therapy or if there is worsening. Okay, so a few slides on tuberculosis preventive therapy. This is the current guideline in India. It was released in 2021. So tuberculosis preventive therapy, two slides on this, because currently India, our goal is to reduce TB incidence. So TB incidence, besides treating those who have disease, we have to prevent TB from developing in those who are exposed. Especially in case of high risk patient, especially children, they become, when they are exposed with TB, especially within the first 2 years of exposure, they develop the disease. So if we give the therapy within the first 2 years, the risk of disease goes down. But that does not mean that the person will never develop TB in life. But in the first 2 years, if TB is not developed, then the risk becomes much less as year passes on. So currently we are giving tuberculosis preventive therapy only for the contacts of sputum positive pulmonary TB. So those who are either positive by microscopy or CB nat is positive. Only those contacts we are giving, not for other TB. So who is a contact? And the contact should be household contact, who has shared the same enclosed living space, whether house, even workspace, as the index patient for more than one night. Frequent or extended daytime periods during 3 months before the start of TB treatment. So even before, like many patients will say, no, after the start of the TB was diagnosed now, but after the TB was diagnosed, my child or we have never gone to their house. But it's not after diagnosis, it's before diagnosis how much of contact was there. So what should we do? For less than equal to 5 years, or those who are people living with HIV, we should rule out there is active disease or not and give TPT. No other tests need to be done. Just rule out whether there is active disease. To rule out active disease, physical examination or any test that you want to do can be done. For those who are more than 5 years old, you should rule out active disease and you should rule in TB exposure or TB infection by doing TST or IGRA test. If TST or IGRA is positive, then give TPT. If TST or IGRA is negative, do not give TPT. But if TST or IGRA is not available and there is no TB disease, our guidelines say to give TPT, tuberculosis preventive therapy. So what is the therapy? 6 months of INH is what is recommended. Currently, the newer therapy that has come, 3 months of weekly isoniazid and rifampicin in people who are old, recommended for people who are older than 2 years old. So this is what is currently recommended under Indian guidelines. Even we can give 3 months of HR also, but government tells 6 months of isoniazid or this 3 months of HP. So the take-home message is, do not treat empirically. Maximum effort should be made for microbiological diagnosis. Nucleic acid amplification test should be the preferred test wherever available. TST and IGRA give the evidence of TB exposure and not active disease. And when in doubt, please consult experts. So this is our NTB. This is what is our SDG goal 20, 25, 30 and 35. This is what we are aiming for, a world free of TB by 2035. I'm not sure. And this is the further reading can be done from this. These are very good guidelines. So thank you for listening. If any questions are there.